So clinical symptoms of pudendal neuralgia are pain in the area of innervation of pudendal nerve, which in women it's clitoris, vulva, vagina, perineum, and rectum. So the pain can be sharp, burning, tingling, numbing sensation. That's a typical neuralgia pain. It's like hitting the funny bone, really. Patients with pudendal neuralgia have pain in that area that's worse with sitting, usually better with standing or laying down, usually better when sitting on the toilet. A lot of patients with bad pudendal neuralgia cannot sit at all. Some patients can sit for 10, 15, 20 minutes, and those are actually the times we collect on patients because that's how we monitor the improvement with our treatments. It's really how long you can sit that is probably closely correlated with our treatment outcomes. Patients with pudendal neuralgia have all these additional symptoms like pain with intercourse, pain with sexual arousal, pain with orgasm. There is all the bladder symptoms that are associated with pudendal neuralgia, which are very similar to interstitial cystitis, which is burning with urination, which is frequency, meaning they go to the bathroom often, and hesitancy, which stands for basically sitting on the toilet and not being able to urinate. Most of the patients with pudendal neuralgia have this sensation of having a foreign body in the rectum or in the vagina in the absence of foreign body. And the interesting thing is that when I wrote several papers on pudendal neuralgia, I searched the literature, and there's no medical term that describes the sensation of foreign body in the absence of foreign body. We have terms for everything in medicine except for that. So I created the word that is allotriesthesia, and allotri in Greek means foreign, and aesthesia is sensation. So in all the papers that I write, we actually use that term allotriesthesia for the sensation of the foreign body in the absence of foreign body.
What about this anal pain? Is that debilitating for these patients?
Yes, the pain, anal pain can be very debilitating, especially anal pain with bowel movements. There are patients that have such a horrible pain with bowel movements that they are asking to have a colostomy placed so they don't have to have bowel movements. There are also patients who have such a severe spasm of the anal sphincter that they can't evacuate. I see patients often that will tell me they use a teaspoon to scoop out their stool because they're not able to void.
What are these women looking like who have pudendal neuralgia in terms of their mental state? This has to be a very demoralizing, depressive problem for them.
So the problem with pudendal neuralgia is very significant because it is not only the pain that those patients have, but it is the pain that affects their sexual ability. And I often see patients that were abandoned by their partners, husbands, because they're not able to have intercourse. What makes the problem even worse is that those patients with pudendal neuralgia, when they go to seek help from other physicians and then they are told nothing is wrong with you, it must be all in your head. Some of the meshes, especially the incontinence meshes, go through the obturator membrane. An obturator membrane is this membrane in the pelvis where it can be easily attached. That's why it was chosen as a site of attachment of the mesh. But also the obturator nerve goes through the same area. If that mesh is not placed properly, then it may injure the nerve.
Or if it contracts and pulls tension on it. So it could even be a well-placed mesh. Are you seeing patients with well-placed meshes in that area with obturator neuralgia?
Yes, we do. I mean, and it's not that I can't really make that statement that it is, contraction of the mesh. I just know that we remove those meshes and patients get better. And yes, they're clearly not through the nerve. I mean, I have seen the mesh through the nerve, but in those cases, I'm talking about the patients where the mesh is near the nerve, but not through the nerve.